Our session today primarily focused on cellular therapies for acute myelogenous leukemia. And we all acknowledge that there are challenges that need to be overcome using effector cells consisting of either T cells or other effector cells such as NK cells. So I'm sitting here with Saar Gill, who's at the University of Pennsylvania, and Rizwan Romee, who's at the Dana-Farber Cancer Institute. I'd say we have overlapping but distinct perspectives on some of the challenges of treating AML. So maybe, Saar, you could jump in and start off.
Sure, thanks, John. I think that one of the interesting observations that I think we all made on this session is that AML should be an immunoresponsive disease. After all, we all know very well that standard of care for AML, at least for consolidation, is an allogeneic stem cell transplant, which is primarily immunotherapy. And yet we've all noted through individual ways, including one of our colleagues who's not here presently, that using different modalities of immunotherapy, be they bispecifics, be they CAR-T cells, that the responses are less than what we expect. And we all have observed again in both as yet unpublished as well as publications that there seems to be a very interesting interaction between the tool, the T cells essentially, and AML or the microenvironment, an interesting interaction that may ultimately actually not be to the benefit of the administered immunotherapy, and something that we need to resolve. And so in that context, I was actually very interested that Rizwan has worked on NK cells, which have similarities as well as differences from T cells with respect to their effector functions.
So Rizwan, can you comment on that? Because NK cells are, obviously they've become the darling of many around the world who are looking for alternatives for CAR-T cell therapy, both in the context of toxicities, right? I mean, with the limited data out there seems to be likely less toxicities in patients, and certainly that's of interest. Number two is that they work when they're appropriately redirected to targets, and so they're effective. They make a lot of gamma interferon, but they're associated with low toxicity. So I wonder if you could comment on that.
No, that's a great question and an observation that there and which is kind of well acknowledged now through multiple studies, that NK cells and NK cell CARs don't seem to cause as much cytokine release syndrome and possibly not cause any neurotoxicity as well. And that may be related to the fact that the cytokine profile, and you showed some elegant data in that regard, that the cytokine profile or otherwise secretome of NK cells seems to be different than T cells. What was striking from your one unpublished data slide was the IL-6 secretion. It was profoundly low or non-existent from the NK cell CARs, even though the construct was the same, target was the same. And yet we know that interferon gamma, NK cells produce plentiful. In our own observations from the clinical trials, patients who have had up to 80% loss in their bone marrow before undergoing NK cell therapies, they don't seem to cause CRS, which is pleasantly surprising, but that may be again related to the fact that the secretome is different. Now, that kind of is well established as a safety-wise, but what is not well known and is something which we all in the NK cell field are striving to do is persistence. I think T cells in general, especially the memory T cells, they can persist for a long time. There was a recent elegant paper from University of Pennsylvania where someone who received CAR-T cells for CLL, almost a decade later, there were some CD4 positive CAR-T cells still persistent and still functional, which is quite dramatic. That kind of data does not exist on the NK cell side. Now, having said that, there's this recent observation that NK cells can achieve memory-like phenotype, and at least those subsets do seem to persist for longer period of time, but still not years, maybe 1 or 2 months. And I think there's a big push to enhance the persistence of NK cells after adoptive transfer. It's a lot to learn. NK cells are, in terms of knowledge, in terms of basic science knowledge, maybe a decade earlier compared to the T cells. I think there's a lot to learn about NK cells, and that's an exciting opportunity, as well as, in terms of intervention, a lot to do, actually.
Yeah. I mean, one of the things that I am, interested in is sort of the actual ability to expand for NK cells versus CAR-T cells is less. But I have to say that, look at some examples of diseases that can be effectively treated without a lot of expansion. For instance, the few NK cell patients that were treated with non-Hodgkin's lymphoma, the actual level of expansion in those patients was not nearly what you see with CAR-Ts, but they seem to have their disease go away. The other group of patients I thought were kind of interesting were, the patients that get CTLs. I mean, they're mismatched, largely HLA mismatched. They often are infused in the absence of lymphodepletion. It's wild. And then they over a long period of time, they can eliminate very aggressive B-cell lymphomas, So, and they have been shown to not really expand very much. But certainly they get to the tumors and they eliminate the tumors. But I don't know if you have to expand rapidly to do what needs to be done. So that's why I think there's also really reason to believe that NK cells will be a really great alternative going forward. You just have to transduce them efficiently. So what's been the problem with transduction?
I think over the years, people have kind of stuck to using or trying to use VSVG serotype lentivirus, and some of our data now clearly shows that that's not the right choice for transducing NK cells. There have been several recent elegant papers showing that if you serotype lentivirus with ASCT2 targeting glycoprotein, which is the baboon envelope glycoprotein, and there's also some others, then you can get the lentivirus construct in. Now, having said that, there are other groups which are using retroviruses and using different other glycoproteins for serotyping. But in summary, I think in the last couple of years, we have seen that there are ways to get different constructs, be it lentivirus, retrovirus, some efforts also Sleeping Beauty based transduction methods. And I think we're going to only see expansion of NK cell CARs and other gene editing because of the advances we have made recently.
Any insights into the best endodomains in these cells?
That's a great question. There was one study which actually compared in NK92 cell line different endodomains, and the winner was the one which had NKG2D transmembrane domain and 2B4 based intracellular activation domain. Having said that, that particular comparison was made in NK92 cell lines, and as you know, not everything which we observe in cell lines translates to actual primary cells. In our unpublished data, when we did the comparison, actually 2B4 versus the 41BB based intracellular, it worked equally well. So there is a paper coming out of MIT group where they have done CAR pool approach. It's pre-published right now. All I can say is that they looked at multiple endodomains in T cells, CAR T cells, and still the 41BB and CD28 topped the list, which is interesting.
Saar, I think that I can safely say that you've demonstrated proof of principle that CAR-T to an AML target works in some patients. So why doesn't it work in all patients that express the target?
I wish I had the answer for that. The things that we are looking at are, I think the obvious ones are, we have the antigen. Is it expressed at this high levels in the responders as it is in the responders as it is in the non-responders? The answer, I think, is that's not the problem. The way we're thinking of it systematically, John, is it patient factors, microenvironment factors, T cell factors, or the CAR construct. And so I think we've isolated the CAR as not being responsible. I think with appropriate preclinical controls, we've shown that that works just as well. And so it leaves us with T cell disease or patient microenvironment, and we're doing some studies now to, in a reductionist fashion, which appear to be, with preliminary data, appear to be pointing us actually towards the T cell, a T cell based lesion, a T cell based, if you like, problem with respect to that. And so conceivably, patients whose T cells are better, are more fit, younger, have experienced less dysfunction as a result of their AML or its treatment, are the ones who are going to have better responses. So that's what we're trying to run down now. So
like NK cells, you think that means that the future of CAR-T cell therapy for AML is going to be an off-the-shelf approach?
Thank you. I think when I've sort of said this publicly a number of times, and actually this is the first time that someone has really nailed the sort of inherent logic. If you follow that logic to its conclusion, then the answer should be off-the-shelf healthy donor. And as you know, there are studies now being done with off-the-shelf healthy donor T cells in AML that may give us the answer to that.
That's great. One of the things that I also was struck by is that CRS is a big problem in either bispecific therapy or CAR-T cell therapy for AML. And we've been working on that, but it is an annoying kind of problem that is coupled with low response rates, high CRS rates. So one of the issues is that for bispecifics, you can just stop them. And that's what you end up doing a lot of the time. In many of the bispecific trials, what's happening is that the drug is being given, and the patients get severe CRS, it's stopped. And so then you start it again. And so you're doing this stop and start all the time, which probably doesn't provide the best chance for eliminating the disease. So CRS is a major problem. And then the other thing is that in addition to that, the response rates are really terribly low, much lower than you would expect. And when you take these same AML cells that are not you can't really induce an effect in a patient, and then you take them and inject them into a mouse, and then use normal T cells. You can kill those AML cells just perfectly. So there's got to be some environmental impact on the T cell responses, which is profound in really preventing optimal responses. So I'm wondering also, we didn't talk about this, but I'm going to ask you. What is the future of macrophage CARs? Since you published a nice paper in Nature Medicine, I believe.
Biotechnology.
Nature Biotechnology, looking at using a novel effector cell for the treatment of various cancers, and especially I think you're interested in solid tumors, so I wonder if you can talk about that.
Yeah, sure. Thanks, John. So I think that specifically the problem with macrophages for myeloid malignancies, as you well know, is since the starting cell population is a monocyte, we don't necessarily know that the monocytes we're getting from our AML patient, in fact, they may well be malignant, particularly AML or myelodysplastic syndrome. So I'm not sure that myeloid malignancies are going to be where I would test autologous macrophage therapeutics. Having said that, there may be some data from others on utilizing macrophages in myelodysplastic syndrome, for example. On the other hand, macrophages have two very different effector function modalities compared to T cells or NK cells, which is they don't tend to kill by granule exocytosis, but rather by phagocytosis and antigen presentation. And it is the latter that I think is particularly interested in solid tumors, because these cells will not only gobble up your cancer cell, but also break it down and then present antigens to T cells and thereby induce a broader immune response.
Yeah, so that cross-presentation might be very important as a sort of a pseudo-vaccination kind of approach. So so the other thing that I wanted to point out was, with your stuff, Rizwan, so what do you think, are you moving forward with this NPM1 approach? Tell me what you...
Absolutely. I think we have seen promising activity in vitro and preclinical mouse models. So we are working on a clinical trial where we'll test this product in patients with relapsed refractory AML, either before transplant, meaning they failed the chemotherapy, or who have relapsed after transplant. I remain optimistic because of two reasons. One, we will use the memory-like platform, which on its own, without any gene editing, has shown modest to promising, at least temporary, ability to induce remission in patients with relapsed refractory AML, including now after transplant. And then if we arm these, so my hypothesis that if we arm these cells further with a CAR which directs towards the new antigen derived from the NPM1 mutant gene, we should see enhanced efficacy of that product. So we are optimistic about it. I think the biggest hurdle has been viral vector, because the viral vector involved is baboon-based, and there aren't many vendors right now which are making that lentivirus. So we are moving forward slowly and steadily. But yes, absolutely, we remain committed.
I like the idea also because, we always think about why people relapse with AML. But my question is, why are people cured with some kinds of AML? And so obviously you're considering a cellular therapy in a class of AML, even though they're relapsed, that traditionally is better and more biologically amenable to therapy. So I think if this is going to work, it might work best in the NPM1-mutated AMLs that you're focused on. So I'm excited to see how this goes. The other is, obviously we've all gone down this rabbit hole, and probably I've dug one of the deepest holes in the world looking for novel antigens to go after in AML, both using proteomics approaches and genomics approaches. And I'm wondering, Saar, I know you've done a little of this. What is your thought? Are there any uncharted territory there? Have we figured everything out and there just aren't any really differentially expressed antigens on AML? So
I think we might have both started digging at the same time. I'm surprised we haven't met in the middle, somewhere deep underground, actually. I, for the moment, have lost some enthusiasm for doing that, and that's because I don't know that there won't be. You've got to start somewhere, and I think it is important to be rational and sort of scientific in your thinking, and I just don't see. I think in the individual patient, yes, there might well be some specificity, but I think when you're developing a drug, that's not something that's workable. And so I, for one, have focused on a different approach, as you know, which is trying to essentially synthesize a leukemia-specific antigen using sort of combination of CRISPR gene editing with CAR-T cells and using the transplant as a platform for doing that. And that's how I think you can, in fact, credibly you can. This has been, of course, reproduced by other groups now. You can credibly make a leukemia-specific antigen in that fashion. Yeah.
So some of the potential approaches have been using, especially in pediatrics, focusing on some of these rare fusions, generating novel antigens. So that's probably going to maybe yield a beneficial target in a small percentage of pediatric AMLs, but probably not too many adult AMLs. And then the other is just a really broad-based proteomic approach to AML and looking at not only regular proteins, but embryonic antigens, modified glycosylation, some of the things that we normally think of as being expressed in germ cells like NY-ESO-1 and MUC1 and things like that. Those are probably not the best examples, but there are other examples of sort of probably embryonic antigens that may be slightly differentially expressed in these primitive cells that might be targets as well. I don't know what you guys think.
I'm hopeful that, yes, AML, interestingly, AML has one of the least number of mutations, as shown by so many people in some of the pioneering work led by your group. And yet, it's hard. It's hard to treat. We are dealing with very small set of driver mutations, and yet, it's been the hardest therapeutic challenge. But having said that, one of the things which excites me about potentially target new epitopes is that if you can find, because most of the cells do maintain ability to express stuff on class 1 and class 2, although in post-transplant setting, class 2 does seem to go down. So most of these mutations, potentially, I'm not saying most, but many of these mutations or mutant proteins, there may be neoepitopes, there may be neoantigens which you could go. But that's not going to be full panacea or anything, but actually that might sway us towards the TCR-like or TCR-mimetic or TCR itself.
Such a tough problem and so expensive to dive in. Again, looking at, especially try to quantitate peptides bound to MHC. This is just a big project, lots of technical expertise, lots of potential issues with efficiency of yielding these peptides and measuring them quantitatively, and then really once you find these peptides, then you have to determine if anybody could ever generate an immune response to them. That's the other thing. And I think it's, there's an interesting group at the University of Pittsburgh who have been developing sort of rapid TCR generation very fast, with any kind of peptide-bound MHC. They have a way of screening libraries for TCRs that bind to them, so within days, and then they can actually subclone the TCRs and express them within a few more days. And so this is potentially a way that people could actually, for every patient, look at their peptide-bound MHC and then go after potential, not TCRs that are made endogenously, but screening a library of TCRs for ones that bind to these peptide-bound MHCs, and then you could go technically quickly into the patient. But again, it's going to be patient per patient, which is going to be something that probably most people won't want to develop commercially. I don't know. I think that's so. I think I'd say that based on our session, there are enormous challenges in targeting AML. I think that that doesn't mean that it's impossible. It just means that we haven't figured it out yet, and it will take a little bit more time. There's probably always some way to, there's many ways to skin a cat, and there's probably a way to do this. And that once you find a way, I mean, you've obviously demonstrated that it can work in some patients, and so there's just a way to figure out how to do it more efficiently and more effectively. And then I think this is going to be one of the last frontiers in hematologic malignancies, AML, and I think we've done a good job with B-cell malignancies, although we don't succeed all the time. And AML and other diseases are going to be really challenges going forward. I think we've made a little bit of progress with some of the other leukemias, CLL, T-cell ALL now. There's a way forward there that is being pursued by some. And I think even in some solid tumors, the data with MAGE-A4 and synovial cell sarcomas looks quite impressive. And so I think progress is being made. But I think that AML, ironically, even though it's a hematologic malignancy, will be a malignancy associated with the fewest neoantigens, will be one of the hardest nuts to crack going forward.
One other thing I want to comment on, and I briefly mentioned it in my talk, when we had a patient who had exclamatory relapse, and we gave highly purified memory-like NK cell CAR, or not CAR, but memory-like NK cell product. And then when we did serial biopsies, what was striking was the number of T cells. So there was some pseudoprogression, some inflammation, and I was sure he's progressing. Turns out it was actually NK cell infiltration, which I was excited about. But when we tried to quantify were there more NK cells or T cells, actually T cell infiltration was more there than the actual NK cells. And they were predominantly CD8 early on, and then they switched to CD4. And that might tell us something, that immune cells are social like us. We like to be friends with each other. And maybe one of the things we should consider moving forward, and that applies to both hematologic and non-hematologic malignancies, is trying to combine or create constructs which actually will force crosstalk between, or rely more on crosstalk between the immune cells.
I guess I just want to, I think that is maybe a critical observation going forward. The other thing is some of the things that Marion had reviewed in her talk, which were spectacular. She gave a terrific talk. And I think this notion of targeting multiple antigens is also going to be potentially transformative, in that could overcome many of the limitations that we find now going after one antigen, not only for antigen escape, but the sync issue and specificity of targeting. And so I think the key for that is to figure out how to target two antigens and have the signal occur only when both antigens are engaged. That's the tricky part of it. And there's a ton of stuff going on there, but that's going to take a lot of work too to get that more efficient and effective. But I want to thank you all for this session. It was I really enjoyed it. It was fun hearing everybody talk about AML and some of the advances and challenges going forward. So thanks.
Thanks, John.